Okay, we're going to start our last session, the complex VT ablation patient. Myself and Dr. Dukapati as moderators. Our first talk by Dr. David Wilbur, sarcoid-related VT, anti-inflammatory, antiarrhythmic drugs or ablation. David.
Well, thank you, and I think some aspects of this talk are going to be relatively short. I think probably because there's a paucity of evidence-based guidelines for much of the treatment of sarcoid, and clearly this has been in rapid evolution. So my goal is really to sort of point out, I think, some of the changes and the impacts and why I think we're really just evolving an evidence database over the last couple of years as we sort of change our treatment. One of the initial, the most recent meta-analysis of steroid therapy for sarcoid included that there's basically no clear evidence for the benefit of sarcoid, certainly steroid therapy for the treatment of sarcoid. Now, that's a strong statement, but it's a strong bit of evidence that things were looked for. There was some data that suggested that patients with severe LV dysfunction would respond to improvements in left ventricular ejection fraction. Very little systematic data, though, about the response of ventricular arrhythmias to steroid therapy. So we'll talk about that a little bit. So I just want to talk about, I thought this would be best discussed in the format of a case. And so this is a 56-year-old man who'd had a non-ischemic cardiomyopathy and an ejection fraction of 40% that was documented about 6 months ago. Had no other clear abnormalities that suggested sarcoid. In fact, had no adenopathy on chest x-ray. He had not had any imaging, but nothing was expected. He had a single episode of VT, and that prompted putting in an ICD, and then he had no further therapies. And then this was around December of 2014, he started having VT therapies, both fast VT, slow VT, 140. All of these were documented by device, but not by 12-lead. And then he started developing heart failure. And then an imaging study was done, and that ejection fraction of 40% from 6 months previous was now 15%. So dramatic difference, and so the managing physician decided it was time to send the patient elsewhere, and so he did end up with us. So he presented with VT Storm, multiple shocks for both fast and slow VT, and interestingly, most of the VT, by the time he got to us, although it started out monomorphic, was now these bursts of polymorphic VT, often that would stop on their own, but occasionally would need ICD therapy after we prolonged them. And we did reconfirm that the ejection fraction was 15%, and so our approach in most of these folks then is to get a MR, and MR imaging certainly then suggested a very concerning pattern of extensive patchy late gadolinium enhancement that involved much of the RV, the LV septum, and the inferior wall. So all of that then, this is clearly a non-ischemic pattern, but in a very sort of nodular way that simply kind of suggests sarcoid, although there's not a definitive sarcoid MRI finding. And that, for us, then prompts very quickly before. He had initially been referred for VT ablation, but we clearly realized there was something else that we needed to look at first. So got a PET scan on the third hospital day, and as you can see, this was grossly abnormal. And there's intense uptake, FDG uptake in the LV, both in the septum and then RV free wall, and also in parts of the LV infralateral wall as well. And then you can see on the other view here the same thing, mostly again involving the septum, but very intense and high uptake. So again, as I said, this patient had no evidence of a non-cardiac sarcoid finding, so had an RV biopsy and had extensive granulomas, non-casein granulomas. So the question is, what do you do in this case? And for us, obviously, now his VT, surprisingly, he had been started on amiodarone, got high-dose amiodarone in the hospital, and with some additional lidocaine, it actually all settled down, surprisingly. And so clearly, the mandate to do ablation, I think, was gone, and what was needed was anti-inflammatory therapy, and that's, in fact, what was started. So over the course, he was started on 60 milligrams of prednisone then initially, and he was in the hospital for about 10 days for his arrhythmias to cool down, and so by the time he was discharged in 10 days, someone who was having 30 or 40% ectopy when he came in was basically had just a normal sinus rhythm and was not getting sustained therapies. I think a couple of interesting things here about his follow-up, and I'll just mention a little of them and then give you a little bit more at the end, was that when we re-imaged him at 3 to 6 months, although his ejection fraction had improved dramatically, the uptake that you saw in the left ventricle and the septum was still there, although the RV had resolved, and it took really 12 months of steroid therapy before the PET scan cleared, and as you can see now, there's virtually no uptake. This is now a year later. His ejection fraction had stabilized, but had never gotten better than 40%, and so obviously there was some persistent scar there. And so here's a sort of an alternate view, the patient with sarcoid and VT storm that was completely managed by anti-inflammatory therapy, and in this case actually with very good resolution, and he never had, after the first couple weeks post-discharge, never had another sustained arrhythmia, though he now clearly has a scar burden, so it certainly won't surprise me if he presents with scar-related VT later. So how do we make sense of all this? So I'm just going to go briefly over this because we don't have a lot of time, but I did want to give you that as a possibility. And the question is now, when we see patients with VT, monomorphic VT or polymorphic VT, should we screen all of them for active inflammation? And then if we do that, what do we do with that data? Do we give an interim period of treatment with anti-inflammatories? Do we do anti-inflammatories, and if they appear to be a good ablation candidate, do that simultaneously? I think these are all options for which there's very little data. I think it's worthwhile in this sort of where does VT ablation fit in to talk about the outcome of ablation, and there's a couple of studies that we'll mention briefly. This is from the Brigham group published about a year ago, which was 21 patients, which was 5% of all their non-ischemic cardiomyopathy. Interestingly, 18 of 21 were already on anti-inflammatory therapy at the time that they went for ablation, although, again, they were on various stages and how active and whether they had PET scans at the time. I think there was not a standardized protocol, so I think that data is unknown, but nonetheless treated. And they did find that actually whether they were on treatment or not actually had an impact in those that were still on anti-inflammatory therapy, implying that there was still active inflammation. In fact, those patients did much worse than the patients who didn't. Obviously, this is not a randomized comparison, so some selection bias there. Found that there were extremely diverse substrate. I think one of the interesting things, as you all know, sarcoid can mimic ARVC, big RVs, lots of scarring, and in fact, they just confirmed that in this. The substantial number of these patients had large areas of confluent scar. So even if it doesn't look like ARVC alone, it's not uncommon to have a very diseased and a sort of right-sided predominant. It's just part of the many phenotypes for sarcoid. And as they went through, it's very clear that the outcome here is tough. It's a challenge. Many different spots, many different VTs. So 1 year VT-free survival with a single procedure, about 14%, multiple procedures, 37%. There was always one VT you could get rid of, but hard to get rid of every VT in every patient and every recurrence. So I think the take-home message is here, diverse substrate, success rate's challenging, and so do you want to jump in and do that ablation right away, or is it worth thinking about doing some anti-inflammatory therapy as well? Here's another series just recently published from the Penn Group, again emphasizing that the high risk of recurrent arrhythmias. This is challenging, multiple substrates. About 75% of the patients had MRI or PET. And again, looking at how the PET identified scar, what you see at electroanatomical mapping with voltage, and what you see with CT, all of, give you a little different picture of the substrate, and did not find the imaging to be terribly helpful in terms of directing as to where the VT was located. But interestingly, certainly having the strongest predictors of recurrent VT were either that there was abnormal inflammation on the initial PET, that inflammation didn't improve during steroid therapy, so that suggested a prediction. And then obviously whether or not you had a lot of baseline inflammation, or rather scar on the MRI scan. So where does that leave us? And the answer is, we're really up in the air. I think this whole idea of being aggressive with PET scanning and looking at inflammation as these patients come in is relatively new in a lot of centers and has really been over the last few years. And so since these centers, since they're not large numbers of patients, it's a little hard to do prospectively. This is a recent review from Bernie, sort of looking at this concept of when patients come in with ventricular arrhythmias, that you strongly consider imaging for inflammation, that you begin steroid therapy. In the Penn study, what they did in those patients that demonstrated inflammation is start them on anti-inflammatories, but also do a VT ablation if appropriate, and then looked at these patients long-term and continued steroid therapy until patients no longer showed imaging evidence of inflammation. Again, just a reminder, there was a task force 2 years ago that published some findings that again strongly recommending that for the treatment of VT, that you start looking for evidence of inflammation and considering treating it. Again, the kinds of doses typically are 40 to 60 milligrams of prednisone a day. So this gentleman, after he did so well at 1 year, he was down to a very low dose of steroids. We stopped it. And he got an echo again in about 3 months, and although asymptomatic, his ejection fraction went from 40 to 30. So we restarted again, and just simply emphasizes the importance that you really need continued surveillance. These need to be followed in a multidisciplinary clinic. And in fact, in this particular case, wasn't able to tolerate switching to methotrexate or prednisone sparing regimens, and he's back on a low dose of prednisone with a preserved ejection fraction. I think that's all I have time to say, and we'll leave the rest for discussion. Thanks.